Good afternoon, everyone. Let's go ahead and begin our webinar. Welcome to the webinar today on translating evidence-based dementia interventions into the community, facilitated by the National Alzheimer's and Dementia Resource Center, which consists of our team at RTI International. I'm Sari Schumann with the Resource Center team, and I will be moderating the webinar this afternoon. The purpose of these webinars is to provide helpful, current, and applicable information for ADSSP and ADI-SSS grant projects and others in the Aging Network. Please note the webinar today is being recorded and will be archived at nadrc.acl.gov, and we will post that website address at the end of the webinar as well. I'll send all the PowerPoint presentations to attendees after the webinar. We will allow time for questions through the webinar's chat feature at the conclusion of the presentations. If you have a question during or after the presentations, please enter those questions into the chat feature. At this time, I'd like to turn it over to Erin Long from the Administration on Aging, Administration for Community Living, to provide a brief welcome.
Good afternoon, everyone. Thank you so much for taking the time out of your day to attend our webinar on translating evidence-based dementia interventions. We are excited to hear from our presenters, Katie Maslow, Jeff Doucet, and Linda Samia. Thank you very much to our presenters, and Sari, I'll turn it back to you so we can get started.
Great, thank you, Erin. Today we'll hear from Katie Maslow, Linda Samia, and Jeff Doucet, as Erin mentioned, about translating evidence-based dementia interventions. Katie Maslow is a visiting scholar at the Gerontological Society of America. The primary focus of her work is care-related issues for older people with cognitive impairment, dementia, and coexisting medical conditions. Before joining GSA in 2016, Katie was a scholar in residence at the Institute of Medicine. Dr. Linda Samia is an associate professor at the University of Southern Maine, teaching in the graduate and undergraduate nursing programs. Dr. Samia currently serves as program evaluator for the Southern Maine Alzheimer's Disease Initiative program. She was also the principal investigator for the Maine Savvy Caregiver project from 2008 to 2014, and she continues to evaluate that program under Maine's Dementia Capable Service Systems project. Dr. Samia served as principal investigator and project director for home care nursing workforce studies in the past. She has been an RN for 39 years with a clinical background in gerontology, home health, hospice, and community. Finally, Jeff Doucet is an analyst with the Nevada Aging and Disability Services Division, where he has worked since 2008 as the manager of the Special Projects team. Mr. Doucet is the project manager for the division's competitively awarded grant projects. He works collaboratively to conceptualize, develop, plan, and apply for funding and to develop or instill specialized programs throughout Nevada. Among these programs are chronic disease self-management education, Alzheimer's supportive services, and lifespan respite. Mr. Doucet served as the project director for Nevada's 2009 to 2013 Alzheimer's Disease Supportive Services Program evidence-based project, which was translating care partners reaching out in Nevada. Our first speaker is Katie Maslow, and I will turn it over to her at this time.
Thank you, Sari, and welcome, all of you. I suspect that many people on this call already know a lot about evidence-based interventions for people with Alzheimer's disease and other dementias and their family caregivers. Some of you probably also know a lot about translating evidence-based interventions from research to practice. So bear with me. I'm going to start with a few background slides that I hope will help to explain the context of the translation work that you're going to be hearing about today. So first, over the past about 20 years, since the mid or late 1990s, randomized controlled trials, RCTs, conducted in the United States and other countries have found positive results for more than 100 non-pharmacological interventions for persons with dementia and their family caregivers. So as you know, RCTs, randomized controlled trials, are the gold standard for rigorous research in this area. And non-pharmacological interventions, we mean non-drug care practices and services. So we have a large number of these interventions now, and more interventions are in various stages of development and testing in the U.S. and other countries. These interventions, the research is exciting because it tells us that there's something to do for people with dementia and their family caregivers, something that we can do that will reduce the negative effects of dementia for people with the condition and their families. The research findings are good news, but they're only the beginning of the process of getting the interventions to the people who can benefit from them. To do that, we need to get from the research phase where we have, as I said, one or more RCTs that show significant positive outcomes for a particular care practice or service. We refer to those as evidence-based interventions, to the translation phase. In that phase, one or more translation studies are conducted to test whether evidence-based care practices and services also work outside the research setting in the real world. And then we can go on to the third phase, which is sustained implementation, in which tested treatments and care practices are provided in the community with non-grant funding, so non-time limited funding. For example, they may be paid for by health plans or provided by area agencies on aging, even paid for by a family caregiver, embedded in Medicare or Medicaid funding. So there are a lot of ways that they can be provided. Translation studies are critical in helping us move from research to sustained implementation. They test the effectiveness and feasibility of the evidence-based interventions outside the research setting. So we know, for example, that an intervention worked in a carefully controlled, selected research sample. But will it work then in a larger, more diverse group of people with dementia and family caregivers? Likewise, we know it worked when it was delivered by trained individuals in the research setting. But then will it work if it's delivered by different kinds of agencies and service providers? Since 2008, the Administration for Community Living, ACL, was the Administration on Aging. ACL has funded 27 grants to states for translation studies to test evidence-based care practices and services for people with dementia and their family caregivers. States have used the grant funding to test 9 evidence-based care practices and services, and some other funders, for example, the VA, Rosalind Carter Institute, the National Institute on Aging, and other agencies and foundations have also funded some translation studies. You can see here, I hope, some of the outcomes from the ACL-funded translation studies. This shows statistically significant improvement on particular outcomes for some of the studies and no significant change for others. So obviously some of the translation studies have outcomes that match the outcomes in the original research and others don't. The translation work that's been done with ACL funding has resulted in a vast amount of new knowledge and insights from real-world implementation of evidence-based intervention. Just some examples here. We know now more about what works and doesn't work and for whom. What's the impact of race, ethnicity, culture, family relationships on the effectiveness of these interventions when they're translated in the community. We've learned who will use particular interventions, what modifications are needed to increase use, acceptance, completion of an intervention, which agencies and service providers can deliver particular interventions effectively, what modifications are needed there, and what kinds of training, mentoring, supervision, and fidelity monitoring is needed. The translation studies have resulted in new tools and materials that will help other states and agencies and providers to deliver these effective interventions in their communities or in their populations, such as manuals, position descriptions, training materials, all information that we didn't have before the translation projects, as well as new delivery methods that reduce costs and increase the number of people that can be reached and served. So really, in terms of the end results, sustained implementation, we have some pretty impressive results right now from the 9 evidence-based interventions that have been tested in the ACL-funded translation studies. You can see them here. One is being reimbursed by Medicare in one Medicare region. 5, at least 5, are embedded in Older Americans Act Title 3D or 3E funded programs. 2 are being provided by health systems, several being provided through the National Family Caregiver Support Program, and 2 of the interventions are now being provided by more than 20 other sites across the country with training and assistance from the people who have done the translation studies on them. So the bottom line, I think, is we have very valuable outcomes. AOA ACL has had significant positive involvement in here. ADSSP funding has been critical. And of course, dedicated grantees and partners who have been willing to work through some of the problems that have come up in implementing the interventions that they've chosen to test in their states. You'll hear of 2 of them in a minute. Just very briefly, just so you know, the Research Center is working now on a paper on this topic that will be available in the near future on the website NADRC, ACL, nardc.acl.gov. Thank you. Linda?
Good afternoon. Thank you for having me and having the opportunity to share some of the highlights of the Maine Savvy Caregiver translation. For years, our mantra here in the state was all things savvy. And what we were trying to do is strike a balance between fidelity to core elements of the Savvy Caregiver program within the reality of the context of Maine to really understand what we could and could not adapt. So briefly, the Savvy Caregiver program is a psychoeducation program. It's evidence-based, obviously, and non-paid family caregivers come together for 6 consecutive weeks, 2 hours per session, and the groups are facilitated by a trained, certified facilitator. And it was developed by Dr. Kenneth Hepburn and colleagues under the premise that caregivers assume a complex clinical role for which they've had little or no training. And so the goal ultimately is for caregivers to increase their knowledge, skill, sense of self-efficacy, and well-being. And we certainly owe much of our success to Dr. Ken Hepburn, and for his wisdom, his experience, generosity. He has just been so generous in his time and consultation with us here in Maine and continues to be. So just a brief funding. We've had 4 grants through either the state and now 1 locally in southern Maine from ACL. And the translations that we embarked on really were the 2 first ADSSP grants that began in 2008. And we had 2 translation phases, the Maine Savvy Caregiver Project and then the Maine Savvy Caregiver Project Advanced. And I'll talk a little bit about each of these. So just to give you a picture of our state, our wonderful state of Maine. We have 5 aging regions, and you can see here the color codes of those regions. And it's a large state geographically, but very small by population, only 1.3 million. Many say that we truly have 2 states divided here by our capital in Augusta, so southern Maine and everything else. So there were significant implications for the translation, given that we had very different challenges in the regions of the state, this being a frontier region up here, really, in Aroostook County. So I'll talk more about what the implications were as I go along. So just to give you an idea of what we've achieved, and then I'll go into details of the translation. Since 2009, when we implemented the first training, we've delivered 267 trainings in the state, reaching just under 1,900 caregivers with the Savvy program. And we're very proud of our completion rate, which over the course of the 2 translations ranged between 87 and 92% of caregivers completing 4 or more sessions, or 2/3 of the program. We've been able to replicate the outcomes from all the early trials, and caregiver testimonies are 99% positive. Caregivers and trainers alike love this program. It's been very successful, but certainly hasn't met the needs of all, and I'll go into that. So the approach that we took, the heart of the matter, which is the heart of the matter of this presentation, and I can't emphasize enough having the right people at the table on a regular basis throughout all of this grant process. It's has been very participatory. So the team approach was key to the translation, and here in Maine, the team included our caregiver experts who ultimately became our master trainers, the program experts, Dr. Hepburn, the resource decision makers like the grant manager at the state level, as well as the organizational managers and administrators, myself as the evaluator, and in phase 2 we involve caregivers in the team for a variety of informative sessions. So, and throughout the process, we've had Dr. Hepburn involved. He came early on. He actually came to the state 2 to 3 times and helped us to develop and then adapt our train-the-trainer model, and ultimately for sustainability. And throughout the course of all of these grants, we had monthly meetings with the team, originally face-to-face, and they were more frequent in the first couple of months, and then monthly via phone calls. Early on and throughout the course of the grants, we had to identify the core elements and really evaluate how we were adhering to these. And these are what we call the untouchables. So for example, in Savvy Caregiver program, knowing that this was based on, dependent on active problem solving of the group members and caregiver debriefing, and that it was not a support group. So those are just some examples of core elements. The practical questions, what did it mean in the state of Maine that was very rural, somewhat poor, and I'll give some more examples of that. The comprehensive evaluation, again, it was very participatory, and I have to say the formative phase is as, if not more important than the summative phase here, because we created a culture of continuous quality improvement, that this was a work in progress, and so we identified where we expected to have problems and continuously were on the lookout for those problems. And we could be quickly reactive to that and proactive. And we used the re-aim framework through all phases of this translation. So just to consider some of the context in Maine, we're the oldest state in the nation by median age. We're the most rural, with 61% of our residents living in rural areas. We're a relatively poor state and limited racial ethnic diversity, as you can see here. But we do have a large Franco-American community, especially in our northernmost county on the Canadian border, and that not created but lent itself to some considerations around language barriers. So this context, we had to consider the transportation issues for trainers and for caregivers, low literacy issues, the pride and independence of our residents, and then the cost involved in terms of travel, especially, one of the great costs for all involved. Additional considerations that we took into account in planning for key partners was that we have a very strong aging network in Maine who work collaboratively and have had tremendous experience with evidence-based programs, and they were well established in the community. So they just lent themselves to being the key partners and continue to be in this project. And then the values shared by residents, that community is a strong core value, independence, autonomy, in terms of taking care of our own. So, so encouraging and facilitating caregivers to even access this program was some of a challenge in terms of self-identifying of needs to participate. So as we all do with these grants, we propose, we have high stakes for what we propose. So in Maine, we wanted broad rural reach throughout the state. We wanted to engage new partners beyond the Aging Services Network. We were hoping to use volunteer facilitators, reduce the number of sessions, because as I said, it's 6 sessions. We hope to reduce to 4 or 5 sessions, obviously maintain fidelity and then sustain. So we had some successes and some tremendous lessons learned, but in this first phase, we did achieve rural reach throughout the state in all 16 counties. And what we did learn early on, though, with the trainer-trainer model, that it really wasn't going to be conducive, the program itself, to using, at least in Maine, volunteer facilitators due to the time commitment of the program and the complexity of the family dynamics and the dyad of caregiver and person with dementia. So we early on learned that we needed to use paid trainers. Also, we learned early on that reducing the number of sessions was not going to be congruent with the core element of the program of active problem solving and debriefing, because it reduced the number of sessions that caregivers could have in between to actually practice their new strategies. So we maintained, for the most part, 6 sessions. There were sometimes, due to weather, that we had to reduce to fewer than 6. One thing that we were able to evaluate, to trial and evaluate, was a shared facilitation model where we had 2 trainers actually become experts in 3 of the sessions, and then they alternated every other week. And this occurred because we had a trainer turnover, unfortunately one due to a death. And so we had to quickly move into Plan B and look at alternate ways of delivering the program. And there was no adverse effect on the outcomes and where there was shared facilitation. So that was helpful, especially in rural areas. We, for the most part, maintained fidelity. There's always challenges with that, and we're able to achieve some additional funding, which I'll talk about. And then in phase 2, the intent was to build on what we had already achieved, but to sustain for the long term beyond grant funding. So looking to embed it in the family caregiver support program statewide. We, based on caregiver input in the first ADSSP project, we learned that caregivers desired more training as the disease progressed. So we proposed to develop the Advanced Savvy program, expand our partnerships, and reach caregivers early. So just briefly, we did develop the Savvy Advanced program, piloted it, created manuscripts, and we have that being offered statewide. We learned that the Savvy Caregiver program isn't effective for all caregivers, and for some early on in caring for someone in the early stages, it may be too soon for Savvy because they're not experiencing some of the behavior changes that are problematic. So, Sullivan, one of the master trainers from the get-go, she developed a 2-hour precursor to Savvy, and that has helped to serve to network the caregivers to other resources as well as introduce them to Savvy in the future. It's informative, and it is also a marketing strategy. Because of the low literacy challenges that we experienced in the first grant, we were able, with some funding, to create an audio MP3 version of the participant manual that helped us in the second phase and is now available for use. And let's see, Fidelity Monitoring, as I said, we attended to this throughout. Our robust train-the-trainer model, having a certified trainer and a process where they attend a one-day workshop, they have required observations, and then they co-train with a master trainer. New trainer observations are then completed. Originally, they were done centrally from the state, but now those are conducted by the master trainers. Fidelity checklists for each training for core elements. Early on, we had all trainers document lessons learned and submitted those, and we reviewed those on the monthly calls, looking for evidence of creep. So examples like caregivers might have shared a comment that they love the video about death and dying. Well, there's no death and dying video in Savvy Caregiver. So we would explore, where did this come from, and kind of regroup around core elements. And then we had workshop evaluations, so we were continuously receiving caregiver input, and we could look at those narratives looking for evidence of fidelity breaches. Lessons learned, we should have had more planning time so that instead of implementing statewide initially, implement in regions, because there were so many regional differences and culture differences within the regions. That would have helped us with our marketing plan to be more robust in each region. We had to plan for staff turnover. I think we underestimated this in terms of trainer turnover, as well as just our statewide grant manager. So again, having a plan for that. We had a lot of central control in the beginning, and learned that we had to really shift this to more local, especially for fidelity monitoring. And obviously, always having a patchwork of funding efforts, because it's the only way that we're going to sustain this. So where we're at now is that Savvy, the original Savvy program and Savvy Advanced are offered statewide. Area agencies on aging are the lead with the master trainers, and now we have a mechanism where all the associate trainers are linked to an area agency on aging, even if they're not employed by the area agency on aging. We have various funding streams, so we still have grant mechanisms, as well as the Title III money funneling through the Family Caregiver Support Program. We've had some funding from one of the universities. We've had organizations such as hospitals, Department of Health and Human Services, the VA, fund trainers and offer space, all kinds of partnerships such as that. And we have central coordination for the trainings, to train the trainers, with some money for those trainings. The manuals are provided through the state, and a statewide scheduling mechanism for access. And we've recently, one agency piloted it through a remote delivery via ITV, and that might be something we try again. So thank you.
Linda, so much. We're going to turn things over to Jeff.
All right, thank you. I'm going to click a couple forward here. Thank you for having me here today. I am Jeff Doucet. I'm with the State of Nevada Aging and Disability Services Division, and this grant was actually our first foray into evidence-based grants. It was a new experience for us. On this first slide, I did a duplicate of Nevada just for conceptual and visualization. Nevada is the 7th largest state, and this kind of shows the area we were covering. We considered it a statewide project, but we were really focused on the 2 main urban areas. So our project, CarePro, Care Partners Reaching Out, it is a cycle educational skills building group-based intervention. It consists of 10-week sessions. There's 5 in-person sessions and 5 coach follow-up calls. For this project here, we actually had follow-up assessments at the 3, 6, and 12-month level. So after the intervention was completed, we'd still follow up within those time frames. The eligibility was family caregivers for a person with Alzheimer's disease or related dementia, providing an average of 4 hours of care. If they had any types of feeling of stress or upset, we did a full kind of quality assessment when they would come in. They would go through our assessment partner. I'm going to cover more of that later. And our goals for this project was to serve 224 caregivers. So our project details, as Katie mentioned, it was 2009 Alzheimer's Disease Supportive Services funding. It was $1 million in federal funding. We provided roughly $584,000 in match, and it was intended to be a 3-year project. We actually had a year-long no-cost extension, and part of that was from the 3, 6, and 12-month assessment follow-up, and spending those continuing analysis in that time frame. Our service areas were in the northern part of the state and the southern part of the state by our 2 Alzheimer's Association chapters. In this map right here, this is housing clusters from our Nevada State Office of Rural Health. The dark red areas are really our focus areas. The red at the bottom is the Las Vegas area. The red at the top is the Carson City, Reno area. We had some rural clients, but that was really our focus areas, and it was a statewide project. But you can see from the other very sparse areas, there's really not much throughout the rest of the state. The southern area of the state houses about 74% of the population, and the rest is dispersed throughout the rest of the state. Between the 2 most populous states, it's about 90% of the population. So our project partners and roles, we had significant contributions from our Arizona partners. David Best of the Arizona Department of Economic Security, they actually had the grant a year before we did in Nevada. So they were really willing to assist us in Nevada and actually shaping up our technical assistance and our process we needed to actually deliver the CarePro intervention. He came to Nevada a few times and presented for our leadership team as well as our administration team and our agency to really highlight the details of the program and how it can serve the populations. And also Dr. David Kuhn at Arizona State University. He, like Dr. Samia said, he was very willing to contribute his time to really help us. He contributed the evaluation components, the training, the technical assistance, constantly helping us with Fidelity and our program partners, their pieces to it. At the Nevada Aging and Disability Services Division, we contributed the project oversight and administration. We did the fiscal components of the grant also. I was a project director, but I actually managed it with the resource development unit manager at the time. She has since retired, but we were kind of managing together. Our agency is shaped, so the resource development manager manages the different subgrants and has 5 specialists throughout the state that oversee those subgrants. And I was more the data component aspect of it. I managed the discretionary grants. The other partners were Cleveland Clinic, Lou Rugo Center for Brain Health. They provided the project screening and assessment. And then the service delivery partners was 2 chapters of the Alzheimer's Association. Desert Southwest chapter in the southern area was also in Arizona, and Northern Nevada, Northern California chapter. So the project being a 3-year project time frame, our first year, we really didn't have any service delivery in our first year. We actually started our wave towards the end of the first year, but it was set up for the process, the training, getting people hired in the program. There really wasn't much hiring. Our program partners, we identified them from the beginning, and they had staff ready to get trained in the program. Later on, we had to hire staff skilled to deliver CarePro. But initially, it was just assigning the partners, assigning the different roles, and getting that process set up. Year 2, we actually really focused on service delivery. We were starting to get the details down, and year 3, we're getting our stride down, and that's when we were kind of doing the follow-up of the assessments too, the 3, 6, and 12-month assessment. Our no-cost extension, I'm going to cover more of that later on, that was a coordinated closeout between us and Arizona because there was some shared components, but that last little bit, it really needed to be a year-long no-cost extension because of our assessments and because of some of the analysis that was needed. So recruitment methods, we used our brochures, we used boots on the grounds, we had word of mouth, and we spoke to our social workers. One of the other grants we actually had at the time was the Medicare Improvements in Patients and Providers Act. We had a community development specialist that was out at various health fairs with her and her team, about 20 volunteers. Well, we tied that outreach to our evidence-based programs, which included the CarePro outreach. So she was actually talking to people in various community settings, health fairs, events, to get that word of mouth for recruitment. We had our brochures and flyers. To the right of this is a sample of our flyer. And we developed them what we called waves. We would get that large outreach aspect to develop enough people to do one wave of the program. So you can see in Northern Nevada we had 10 waves, 98 people going through the waves, and Southern Nevada 23 waves. It was actually a little bit more difficult to recruit in Southern Nevada than it was in Northern Nevada, and we never really figured out why that was. Our Southern Nevada partner actually was trying all kinds of aspects and really humbled themselves and said, look, we're trying everything. Any suggestions you have, we will try more out there. They just weren't getting the same efficiency as we were in Northern Nevada. And we think a lot of that was really the tipping point. Even though they were doing it in Arizona and had some previous history with it, just wasn't getting those people to refer into the program in the southern areas of the state. So their waves weren't as efficient as northern waves, but they were out there busting everything and just trying to get people into it. Towards the end of the grant, we actually had a lot more of those efficiencies happen. Our total completers were 189, and a completion rate was about 88%. So the project flowchart with our 3 partners, after the people were recruiting into the program, they were given over to our Cleveland Clinic, Lou Rubo Center for Brain Health, who would do the initial screening. They would see if they're eligible for the program or ineligible. If they were not eligible, they would identify other resources that might help them out and rescreen as appropriate. If they were eligible, they would do the verbal consent, get them to the service delivery partner, the 2 Alzheimer's associations, who would do the intervention, and then the Cleveland Clinic would do their follow-up assessment phone calls, the 3, the 6, and the 12-month assessment. So our service populations, I want to make sure I included a data tab in here. For our published reports, we had a lot more of the data tabs. But it was definitely mostly white, non-Hispanic populations we served. We did have some success with Hispanic populations using the Promotora model and outreach. They don't quite mirror the demographics in Nevada, but they are pretty close. Nevada's population is about 70 to 74% white population, 26, 27% Hispanic, and Black or African American is about 8 to 9%. So it's not quite on there, but it's fairly close. In terms of other data details, we definitely served more males with dementia and for more female caregivers. It was kind of a broad aspect. There's 22 male caregivers versus 192 female caregivers. It was a statewide project, but like I said, we were more focused in the rural and the urban areas, Southern Nevada urban and Northern Nevada urban. We did have a few outreach into the rural areas. During the project, we actually had some innovative outreach areas. Our Southern Nevada partner was doing a cross-border with Laughlin, Nevada, and Bullhead City, Arizona. Now, for Nevada, I don't think there was anyone during the grant period from Laughlin who did the intervention, but it was very innovative to have it doing that cross-border recruit for the different waves. Our Northern Nevada partner was actually getting a lot of relationships into the tribal areas. So they were able to go in there. I don't think we had any tribal participants, but they were able to get in there and share some information on CarePro. So definitely Fidelity was an aspect of the program. Dr. David Kuhn contributed lots of time, but he was our guidance for Fidelity, making sure we maintain fidelity to the grant, to our proposal, and to the delivery of CarePro. He was constantly doing our technical assistance calls with our program partners, coach calls, and team meeting calls. He was the ultimate say if we ever had a question. We established a process, but when those recruitments came, if there was ever a question, it would go back to Dr. Kuhn for that final authoritative decision. Cleveland Clinic, they had their own IRB along with Arizona State University, so we were working with 2 IRBs for the process. So anytime we had a change in a flyer and change in the verbiage, it would go through the Cleveland Clinic IRB and also the Arizona State University IRB. Cleveland Clinic, the screening, the informed consent, verbal consent, the assessment and follow-up, and the Alzheimer's for the service delivery, they had to maintain that fidelity and that service delivery of CarePro. As we got to our no-cost extension, we were actually transitioning from the grant aspect of it, where we're doing the 3, 6, and 12-month assessment, to what we called our sustainability mode. So in the no-cost extension, because of those 3, 6, and 12-month assessments and the closeout period, there was shared analysis between both Arizona and Nevada. So even though we had separate reports, we still had some components that were tied to both of the processes. So we collaborated on various aspects, and then we had our 2 finalized reports. That no-cost extension period was very critical for us. It really helped us, definitely meet our numbers, but expend that and do the final analysis in that last year. We were very close to our numbers in Nevada. We didn't quite make our 224, but we were about 189, I think it was. Some of the challenges and opportunities we had, and I did consult with Dr. Kuhn on this, definitely we had a lot of the administrative challenges. In Nevada, we have to work with our interim finance committee just to accept federal funding, and we've had improvements since this period of time, but at the time it could take up to 6 months sometimes to even accept federal funding into Nevada. So once we were able to go through our IFC, it didn't take us 6 months, maybe about 3 months at a time. We got our first awards out in January and our next awards out in March and April, which was actually a pretty quick time at the time for Nevada to get those subcontracts out to partners. The IRB, our partners had some deals with that. It wasn't too extreme. As we worked with the IRB, occasionally it would go back and forth and get a change done. It didn't delay it too much, but it was one of those constant things we had to worry about. New staff, there wasn't much turnover of staff to grant. We did, after the no-cost extension, kind of go to a train-the-trainer model. It was always a concern. We did have maybe one staff leave, but they were always able to adjust with people in the Alzheimer's associations. With our recruitment, we definitely struggled with that. There was a turning point when we were getting more of the recruitment in there. Initially, it was some of those barriers. When you talk to someone, a stressed-out caregiver, and you tell them we have a great intervention, we need 10 weeks of your time, a lot of times they're very hesitant. Well, when they went to the program, they had very positive things to say, but that initial recruitment was always a struggle. Once we got the word out and went to that tipping point, it really helped out a lot. The other aspects we had was sometimes you're just looking for something different. It's that stress factor of going to an evidence-based program, and sometimes they just want, I just need a flyer, I just want a book, I just want something simple. Current CarePro, we are still delivering the CarePro intervention. Both our partners, Desert Southwest chapter, the Alzheimer's Association, and Northern Nevada and Northern California chapter are delivering it. We fund it from our Older Americans Act funding, our Family Caregiver Act, and our Tobacco Settlement funding. So Title III-E of the Older Americans Act and our state funding to deliver the programs. It is in our sustainability mode, so we don't have the 3, 6, and 12-month assessments. It's kind of a pre and post we do with the grant. And our northern partner does one CarePro every other quarter, and our Southern Nevada does one every quarter. Service areas, we're expanding more. We still focus in the urban areas, but we are expanding more to the rural areas of the state. We do consider everything we do at the state level a statewide program. And we are getting that tipping point where we're getting more people to recruit, more people to call specifically for the CarePro interventions. And if you have any questions, I'm Jeff Doucet, and please feel free to call me or email me. I love talking about this grant. We did great work with it, and it's definitely one of my passions. I love that we're still continuing this program. And thank you very much for your time.
Great. Thank you so much, Jeff, Linda, and Katie. We're going to move straight to the questions. Now you can enter your questions into the chat feature that you see in the center of your screen titled Q&A. We have a few questions already, so I will go ahead and start with the first one. For all of these programs, the participant is wondering if the funding paid for all the costs for time, supplies, etc., or did participants have to pay a fee for the program? So Linda and Jeff, could you address that question?
Hi, this is Linda. In Maine, participants did not have to pay a fee for this program. So the grant funding paid for all costs. There was certainly in-kind contributions also, and many of our partners contributed sources, maybe not direct funding, but resource support to deliver the program. We still, I'm pretty sure that no one is charging yet for Savvy in Maine.
And this is Jeff in Nevada. We did not charge participants for CarePro. The grant covered the cost, and we still do not charge participants for the cost of CarePro as we continue the program.
Thank you. The next question for Linda. You mentioned some caregivers weren't ready for the Savvy Caregiver program, so you implemented a precursor program to expose them to the idea. Can you talk a little bit more about that program?
Sure. So the program, I cannot take credit for it. Ian O'Sullivan, who really has been our lead trainer in the state of Maine, she, as we were evaluating in our second phase of translation and had a goal to reach caregivers earlier on, she identified with some of the caregivers who maybe had enrolled, had been screened for eligibility, that the person they were caring for was not experiencing some of the behavior challenges that others were in the group, and they just weren't ready for Savvy. So she designed this 2-hour precursor, so really about cognitive losses and some basics and what to expect in the future, and introduce caregivers to that. Some caregivers participated in this program who couldn't commit to the 6-week session. So it was offered as just an extension, an introduction, and it linked them into the aging network and the family caregiver support program, so that in the future they might come back to Savvy Caregiver.
Great, thanks, Linda. Linda and Jeff, can you talk a little bit about transportation and if it was an issue for caregivers? And then also, was it difficult for them to find coverage to care for the person with dementia that they were caring for while they were attending the program?
That's a great question. I'll start out with definitely transportation was a problem. And we still haven't found real great solutions. Well, the one solution was to bring the program out to the caregivers, reach out into the community as far as possible. So we use lots of different settings to offer it, and especially in the rural areas, just going into the community, into libraries, into fire stations, et cetera, and offering the program there, rather than in our southern part of the state. More often the trainings are offered maybe at the area agency on aging or the Alzheimer's Association or hospital, and the caregivers are doing more of the travel, but it's fewer miles and less time. As far as the respite issue, we were able to link into some of the respite dollars, and we have some state respite dollars to try to coordinate that for caregivers, as well as in one region of the state, they actually offered Savvy in an adult day center. So the person with dementia was in the adult day center while the Savvy caregiver training was offered. Actually, we've done that in more regions of the state, and that's worked very well.
And this is Jeff. We had some issues with transportation. It wasn't really the blatant expressly stated that we can't get there because of a transportation issue, but it did come with the lower number of people in various ways. So we had some of that from our partners. It wasn't too specific. For respite, we use state dollars also to provide respite to people who attended the programs, and that was very appreciative on their part. That they definitely welcomed that little break they had, as well as the education.
And I will say, just to add on to this, one thing that we really don't know, and this is, when we were evaluating REACH using the REAIM framework, we don't really know who we didn't reach because of transportation. So we know that 60% of the caregivers that we've served are from rural areas in the state, but there are many caregivers we're not reaching. And one of the things that's in progress with Savvy is a telesavvy that Dr. Hepburn is exploring and has, I believe, some grants now. And we really need something like that to reach the most rural caregivers.
And absolutely, I agree with that, because that is a direct component. We serve the ones who are able to get there, but you never know about those that you might not be able to reach because of that issue.
Thank you. Can you both talk a little bit about the measurable outcomes and what were the outcome measures that you used?
Jeff, do you want to start? Or?
Sure, I'm looking them up right now. I'm going back in process there. Give me one second.
Can start. Okay, then while Jeff is doing that, I can talk briefly. We actually use the same outcome measures that were used in the original RCTs for Savvy Caregiver program. So we measured, we used Perlin's mastery scales, and we used multiple subscales by Perlin, and we used Linda Terry's scale for evaluating behavior change and response to behavior change. We also used a self-efficacy scale, and I can provide the information of the specifics to all of the scales. One of the things that we did run into during the initial translation, it was a pretty extensive pre-post questionnaire. Our completion rate was very high. Participation rate was very high, but it was long because we used a number of scales that already had established reliability and validity. But I can share the specifics with, for those.
And this is Jeff. Sorry, it took a minute to look it up. We based it off of, well, Dr. Kunas, they based it off of the READ Coping with Caregiver trial. It was a reduction in depressive symptoms for caregivers, an increase in use of positive adaptive coping strategies, a reduction in use of negative coping strategies, and a reduction in negative interactions with other members of the caregiving social work network. Again, we can also share that too. I think it was published on the resource webpage, but we can share those specific things that we achieved here in Nevada.
Great, thank you. We have a question about working in diverse communities. Did you either of you find that you needed to make any adaptations to your interventions to be culturally appropriate? I know, Jeff,
Hello?
Can you hear me?
I can start with that.
Great.
As we were going through, we delivered it only in English. There was some translation to it later on where we were going to Spanish, but our outreach to those other populations was the promotor model, the community health worker. We were kind of setting that up within our state unit at the time. So we were working to get more of our programs out into the specific communities. In Nevada, and I remember they mentioned in Maine too, they had like a different north-south aspect. We had that same here in Nevada. We had the north and the south, and we had the rural and the urban. So when we identified those community development people and those specific partners, it helped our recruiting in those areas. The promotor, community health out, community lay worker, that helped us reach specific populations. As for the change in the program, no, we didn't change it during the grant.
And this is Linda. We really didn't do any cultural adaptations in Maine. As I said, we had some language challenges up in the northernmost county on the Canadian border, and there was some French translation, but not really a cultural adaptation.
Great, thank you. We have time for a few more questions. So one of the questions was asking about what are the benefits of a live program versus some obstacles that may be encountered with other methods of delivering the same information through an intervention or just the same information through maybe a book or an online course. Do you have any information about that?
You want me to start that one, Linda? Or?
Sure, go ahead.
So one of the things we actually experienced with the live sessions was we had groups continuing to meet after the CarePro intervention. So the CarePro waves would still meet for years afterwards and still get together and still talk. So what they achieved in the actual intervention had some follow-up aspects to it. They would have that community support, that group dynamic continuing after that process. So I think that would be a big component for continuing these is that actual intervention coming together because you have that social aspect of it that can continue after the program is delivered.
And this is Linda. Sorry, can you just repeat the very beginning? Was it the benefit of meeting face-to-face versus like a telehealth? I didn't hear the very beginning of the question.
Yes, the benefits of meeting in person to give this information that for you that's in Savvy versus maybe getting the information in a guide or in an online course.
Oh, okay. Well, for really, because of the nature of the Savvy Caregiver program, it is psychoeducation, so there has to be active participation. It's not passive learning. So fundamentally, the core of it is active learning and active practicing. So learning new skills, problem solving, being able to use one another within the group, tap into the experiences of one another within the group and the expertise, and to practice, come back, debrief, and problem solve again. It's trial and error. So they wouldn't have that in a passive experience of having a book. And the same in Maine. Many of the Savvy groups formed their own support group. And we talked about ways, many of them were face-to-face, but we try to create some mechanisms and support groups if they wanted to do an online support group after that or have some other way. You know, certainly they exchanged their own numbers. But they formed their own support groups and would facilitate themselves going forward beyond Savvy.
Great, thank you. We have another question about recruitment. I know, Jeff, you talked a little bit about some challenges with recruitment. One of our participants is asking if you can both talk a little bit more about the methods you use to recruit caregivers for the program, especially if you ran into any problems convincing primary care physicians that you had a program that might actually assist the family caregivers of people with dementia.
So,
go ahead, Jeff.
Go ahead.
No, well, I was going to say we didn't necessarily have difficulty convincing the primary care providers of the value of it. It was more making them aware, and that has taken a long time throughout the state. And, you know, there's some relationships that are more clearly established between primary care, between clinical and social service network. So, and there's some mechanisms for referral, and that's improved over time. But the strategies that worked best for us were to engage local partners to help us recruit. So if we were using, for example, we used adult education programs. So we would embed it within adult education in local communities, and the adult education personnel who are known to the community would help us recruit to the program. So that was probably the best strategy for us. We did some public service announcements that helped too, but it was really trial and error, and it varied from place to place. Some agencies relied mostly on, not agencies, regions relied mostly on their agency on aging recruiting. Some used web recruiting. It really varied, so we had to evaluate that. That was part of the ongoing evaluation of what was working and trying to replicate that in regions.
And ours varied also. If I could say there was one thing that was really the effective aspect of recruiting, it was that word of mouth. It was that individual saying, no, I got this great program, you should try it out, and give this entity a call, it'll help you out. And that was our most successful aspect of it. We had the brochures, we had the flyers, we had the health fairs, but when you had someone who was trusted or a position of trust, whether it was a family friend, someone who went through the intervention, a social worker, or someone they worked with and said, this is a great program, you need to go through it, that was our most successful aspect for recruitment.
Great, thank you for emphasizing that. And thanks again to everyone. We're out of time. I know there's a few questions remaining. You can see my email address in the closing notes. If you want to forward any of those questions directly to me, I can divvy them up appropriately to the speakers, or you can contact them directly using the information in the closing notes. I want to thank our presenters for joining us today and for this great information. A few reminders: I will be sending the PowerPoint presentations when we close out here. And also, Katie mentioned the Resource Center is putting together a paper on ADSSP grantee experiences with evidence-based grants and evidence-based programs, and that will be out in the near future. We also have a resource guide on measures that can be used. That is available on the nadrc.acl.gov website. And finally, just as a reminder, you can always contact me if you weren't able to catch any of this information and would like me to send it to you via email. So thanks again, everyone, for joining us, and we look forward to having you on another webinar in the future.
Yeah.